This week's Ask Dr. Durie is another question on an individual patient case, but I'm answering it to help this patient, but also because it is more broadly applicable. So this gentleman is telling me that he's been in remission for 9 years now at the VGPR level after having received an autologous stem cell transplant. And so this is obviously wonderful news. The question, though, is that his light chain level has been creeping up slightly at a very low level, and he wants to know what should he be doing at this point. He's had some mixed recommendations. One recommendation was to immediately do a second transplant, which, as I'll mention in a moment, is certainly an option, but maybe not something to do right away. And so what do I recommend right away? Well, when the light chain level is creeping up, this does not indicate a definite relapse or what we call progressive disease, or you'll see it written as PD, progressive disease. The documentation for progressive disease is that you would have a much more substantial increase in the light chain level or the protein level. For example, if I translate this into an IgG level, it's got to go up by at least 25%, and it's got to go up by at least half a gram. And so a minor blip in a light chain level does not qualify. So what you might have in addition to that, or instead of that, would be the development of one of the CRAB features. So the blood calcium might go up, there might be a change in the kidney function, some anemia, or perhaps a new bone lesion. And so the first thing to look at if the light chain level is drifting up is to say, okay, well, let's double check these CRAB features. Let's make sure that everything is in order and there's no other indication of relapse or progressive disease. And so this is the first thing that I would recommend. In this particular case, since the gentleman seems to be doing very well, I suspect that testing will turn out to be negative. But if anything is amiss, it may be that bone marrow is required, where you might even do some chromosome fish testing, or some more detailed imaging would be required to check out some question of a new lesion somewhere. But if this is all completed and negative, I think the very best thing to do would be to continue monitoring closely without actively intervening in the absence of relapse. And so what about the question of the stem cell transplant? Well, in this scenario, after 9 years, the transplant has been a very, very good treatment. So if relapse does occur at some point, considering a second transplant is very reasonable. The cutoff for that we use is typically if there's been a remission of at least 1.5 years to 2 years. And so this gentleman at 9 years is way beyond that. And so clearly the high-dose melphalan has been very beneficial in this case. However, although it's an option, at the same time, this year, moving into 2017, there are so many excellent novel combinations. We just heard data with daratumumab combinations, which look very promising. I think at any point when a relapse occurs, we look at all of our options. And so a second stem cell transplant, certainly worth considering, but also take a look at some of these newer combinations, and depending on the situation, see if maybe another combination could be considered to get an excellent second remission. And so a very important question. The key thing is to not jump to conclusions, to not rapidly switch to some therapy that might have a lot of side effects. Just look carefully and document the status of the myeloma before making any radical decisions.